Welcome to the Metropolitan Club. I'm Carol Looper. I'm a member of CMC's Board of Trustees. I call myself a retired journalist, but you never retire as a journalist. Good to see you all today. Today, CMC and Ohio Health present Our Health Community. Our forum today, it's a mental health issue with series support from Ohio Health, Mount Carmel Health Systems, and support from Osteopathic Heritage Foundations and Nationwide Children's Hospital. Please help me thank them. We all hear the latest news of crime, gun violence, drug addiction, and teen suicide. It's a mental health issue, is a common refrain. Studies confirm our youth's chances of having a mental health issue as being 1 in 5, with most going untreated. What's going on? Well, let's explore the issues today with our experts. Please welcome CEO, Directions for Youth and Families, Dwayne Casares. Medical Director, Psychiatric Emergency Services, Ohio Health Behavioral Health, Dr. Megan Shabbing. Director of the Ohio Department of Mental Health and Addiction Services, Tracy Plouk. And a woman who I bothered for many years when I was doing interviews with her, former Columbus Health Commissioner, Dr. Teresa Long. The podium is yours.
Thank you, and I was quickly going to grab the microphone, but I've been told not to. So good afternoon and welcome. And again, thank you, Carol, and thank you to our sponsors. I am pleased to be here to consider with you and this esteemed panel the various aspects of this important issue, really an important issue of our time, mental health, and to continue the conversation with good information and actual experience, because I'm not sure if you've had the experience, but as Carol mentioned, it's a phrase that we hear so often these days. It's a mental health thing. It's a mental health issue. And that's really a showstopper. It really ends conversations as opposed to help us appreciate what more do we need to understand. How can we address these issues either in our family, in our neighborhoods, in our workplaces, in our community? So this conversation is to continue or to engage that conversation, to learn more, to better appreciate what's going on, to have thoughtful next steps. I hope we'll have some next steps as far as either individuals or as community members when we take this on. So let me just set the stage for a little bit and we will go to the panel. 1 in 5 of us, as Carol mentioned, that includes our children, experience a serious mental health challenge or disorder. Many more, in fact, may have issues over time or at different times because mental health is not static. But most people who have mental health challenges don't get the treatment that they need. In fact, a recent survey, the National Survey on Drug Use and Health, indicated that 58%, 60% of young people with a major depressive episode never got any treatment. So this is real. The incidence of death by suicide and emergency care utilization are going up. The data is there. And despite serious efforts to expand treatment services, it feels as if we're under mental health. We also recognize, and I think it's becoming increasingly known, that prevention and early intervention services are needed to both moderate the access to care challenge that we have, but obviously to improve and to protect our overall mental health and wellness, both of our children, of each of us, and of course of our families and community. So the goal, of course, is to identify in this conversation some of the challenges, some of what's working, what do we need to think about, et cetera. So let me say one other thing. What is mental health? And then I may turn to ask Tracy or whomever to talk about mental health and behavioral health, because it's slightly different as well. But mental health includes our emotional, our psychological, our social well-being. It affects how we think, how we feel, and how we act. It also helps determine how we handle our stress, how we relate to others, how we make choices. Mental health is important at every stage of life, from childhood and adolescence, obviously through adulthood and older adulthood. So over the course of your life, life, you may experience mental health problems. Your thinking, your mood, your behavior may change, and there are many factors. Some people are just now realizing that, in fact, there are biological factors to our mental health. Yes, brain chemistry is very real. Our genes are a very real component, and certainly life experiences. So trauma, abuse, cultural issues, situational issues are all important factors. And yes, there is help available. We hear about it, and yes, people recover. So with that, to set the stage, Tracy, from your perspective, what do you think the current state of mental health and behavioral health is here in Ohio, and what trends are of particular note to you or of concern to you?
Thanks, Teresa. Behavioral health, just as a point of departure, is generally seen as a broader scope of circumstances than mental health. Behavioral health would include addictive disorders, substance use disorders, even gambling disorders. We also look at overall wellness and well-being and resiliency as a part of overall behavioral health, particularly when we're talking about young people and even very young children. I think Ohio is a very diverse state, 88 counties. You have 88 different sets of circumstances as it relates to resources, workforce, collaboration. So no single community is exactly like others. I think generally speaking, there has been expanded access to healthcare services that has been made available through the Medicaid expansion in Ohio. More than 630,000 Ohioans have received at least one mental health or addiction service that has been reimbursed by the Medicaid expansion since January of 2014. So that's very significant, and I think that it's a lot of progress. Some of these individuals would have accessed services through the local ADAM boards, but some of them would not have. So I think that's certainly positive. I think we continue as a state to struggle in different ways with workforce. These are typically not very high-paying jobs, but they're very critical to support someone to connect with recovery. And so recruitment and retention is an ongoing challenge. It plays out differently in cities and rural areas of the state, but that's one challenge I'd put on the map right away.
Great. Well, I appreciate that. And of course, it's the entire state, but this group is probably more focused on right here in Central Ohio. So thank you for that. So speaking of Central Ohio, what is it, Dr. Shabbing, Megan, that our patients, our families are experiencing, and our providers? Obviously, you have a firsthand experience as far as what's going on right here in Central Ohio. What concerns do you have? What trends do you see, et cetera?
So despite Medicaid expansion, access to treatment is still a huge problem on every level. So if you're somebody out there, even if you have private insurance, which in theory would be the best case scenario in terms of access to treatment, if you've ever tried to see a psychiatrist or gotten a family member into a psychiatrist, even with private insurance, it can take months. And for many people, that's way too long. That's just not okay. From the patient perspective, it's oftentimes not just a matter of having a place to go, a community mental health center or a psychiatrist where you can get medication and therapy, but for many of our patients, when we ask them, what keeps you from following up with your appointments? Why aren't you going to these appointments? We keep setting up these appointments for you. It's sometimes the most basic things, like I don't have a way to get to my appointments. I don't have transportation. I don't have money to buy a bus pass. For many people, they have trouble staying on their medications because they just don't have anywhere to put their medications. It's hard to keep track of your medications when you're staying in a shelter or when you're going, they're couch surfing from place to place. This particularly seems to be a problem in terms of our patients with opiate dependence and other substance abuse disorders, because for so many of those people, because of the addiction, they've burned all their bridges. And when I try to say, who can we call from your family? Who can we reach out to and try to advocate for you? Just to have a safe place for you to stay until we get you to your next appointment. And they have nobody. I mean, nobody everybody's sort of done with them. So it's not just getting somebody in to get the treatment that they need, but it's providing all of those other pieces to the puzzle that are necessary to kind of follow through with a treatment plan, whether it be for schizophrenia, bipolar disorder, depression, anxiety, or substance abuse disorders.
If I can add, that difficulty in accessing services is critical because often people will interpret that as, well, they're just being resistant to treatment, or they'll start to blame that person. And when you look at childcare and transportation and these types of barriers, it really paints a different picture. And the transitional nature of the populations that we serve, this doctor may have been close, or this mental health clinic may have been close this week, but next month, when I end up getting moved somewhere else because I've been evicted, now all my circumstances change. So I think, number one, we have to give people a break about these things. It's not like they're being resistant to treatment. All of us, if any of you have been on medication for like an antibiotic, to complete the entire cycle, often people stop doing it. So it's not just because there's a mental health issue attached to it, doesn't mean they're any different than any of us. And many people self-medicate. So these are just challenges. I think we have to have a different view of how we look at mental health and how we end up judging those who end up. Actually, I just think people who go for services are people of courage. And we have to reframe this so that people understand asking for help is not a deficit. It really takes an awful lot of courage and bravery to take that step into any type of treatment.
Right. Super. And actually, Dwayne, you just jumped into the conversation. I'm going to go back and give you another chance if you'd like to add anything else as far as challenges, but clearly we'll come back. I think I've just learned more about these social determinants of mental health challenges. I think many of us have talked about the social determinants of health, but you're already naming some of them. But let me come back to, because Dwayne, you are in such an important place, both as having been a direct provider, worked with youth and families, and oversee an important organization that's working in so many settings in this community, trying and making a difference. Do you have thoughts about what are the greatest or the newest challenges that young people, that our families, that our community are facing?
I don't know if they're new as much as I think at sometimes they've just expanded. When you really look at isolation at times, that becomes very difficult. Support systems are more challenging. When you have single-parent households that are worried about putting food on the table, that's a little bit different, so I can't be attuned to all these other things. I think access, thank goodness we're in Ohio that has Medicaid expansion, because that certainly helps a lot of people who traditionally wouldn't be able to reach services, so thank you. The challenges are different for each family, and you have to adjust accordingly. 30 years ago, we went as an agency to all outreach services. So we were in the homes, we're in the schools, in the community. That's where we end up practicing. A lot more people are doing that now. I think you need a continuum. I think there certainly is a place for office-based services, but you certainly do need a continuum for those people that are really hard to reach or in areas that don't have a whole lot of assets that are available to them.
I think, too, there's been a growing recognition of trauma and how the effects of trauma impact young people and their overall trajectory in life. And we've had an initiative underway with a broad host of community partners to educate folks. Not our providers are very well attuned to trauma and its effects, but talking with first responders and training folks in schools and training child welfare workers about how this impacts people and how engagement strategies on a personal level might be changed in order to recognize trauma more effectively.
Well, that's super. This conversation's going off in directions I would love to see it go. So let's talk about trauma, adverse childhood experiences, et cetera, because that's part of what I think is newer information, and not that this community hasn't thought about that, but I know, Dwayne, your organization has been absolutely committed to having that be centerfold to what you're doing. So how would you share either what's working, and maybe Tracy or Megan jump in as far as, and then we'll bring it back around, but what has the research shown, what has the experience shown as far as what works as far as programming and services in this arena? Well,
we certainly do know that people who are exposed to toxic stress, this really has, actually, from a medical standpoint, it has a life expectancy issue as well. People with a trauma score of 6 or higher are 4 times more likely to get heart disease, and 3.5 times more likely to get cancer. So this is really the combination of the physical health and the mental health has finally come together to start to address this on a very, very serious level. If you really look, 5 years ago is when we first started working with the Trauma Institute out of Boston. At that time, one of the things that caught me is when you started looking, think about it, everybody in this room probably knows somebody who is on medication for ADHD. 10 years ago, I used to think if this is really the case, we have a national epidemic. What the research has done on trauma and adverse childhood experience has shown that unresolved trauma those symptoms mimic ADHD. So when you consider that, you have to consider the fact that then we are unnecessarily medicating people who needed a different course of treatment. So I think we've all gotten much better at it. I don't think there's anything we can turn our back on. We have to keep pushing this message forward so that we can get people the best possible care that they need in order to transition in their lives.
And Dwayne, I think you're right. I mean, when we talk about trauma, there's so many different faces to trauma, and we see this all throughout the healthcare system in so many different ways, shapes, and forms. So I'll give you an example. I think classically we think of trauma as the war veteran who has classic post-traumatic stress disorder, the nightmares, the flashbacks, the hypervigilance. That can often drive substance abuse, and that's a terrible problem. But we also see people coming into the hospital with what looks like a neurologic problem, and these people end up on the neurology unit getting test after test after test, you know, MRI, EEG, extensive neuropsych workups, and everything ends up negative. And at the end of the day, we're left with the fact that trauma and anxiety can actually manifest as a medical problem, a neurologic deficit. We also see trauma with our younger patients. So even though I'm at an adult hospital, we have teenagers oftentimes coming into the ED, and we have suicidal teens come in who have been traumatized via social media by cyberbullying. And this is a huge problem right now when I think it's, you know, almost half of kids will say that they are connected to the internet. I think it's 25% of kids will say they're connected to the internet virtually at all times. And if we don't start keeping an eye on our kids and our teens and what they're watching and what they're exposed to on YouTube even, they can really see traumatic events in different ways. And that's something I think that's a little bit newer with the emergence of social media, but we've got to know what they're doing with their screen time.
Wow. So this is great. Let me come back to a couple things because we're going to keep teasing these out. But just on the traumatic and learning about the ACEs, the adverse childhood experiences, the work around resilience, and then Megan, Dr. Shapping, I really appreciate your jumping in because it broadens the conversation to think about post-traumatic stress disorder. But really, I mean, there's so much stress and toxic stress in our world. What do you see when people come in? You've given a good example of being on a neurology ward, but what do you see in the emergency department? What are physicians either seeing or observing or experiencing that are helping them, and what works to quickly identify and support people who are having these kinds of traumatic reactions? And obviously it's challenging their mental health, whether there's underlying mental illness or not. Are there things that are working, whether it's right at the emergency or moving on into community-based support and therapy?
Yeah, in the emergency department, we really try to meet the patient where he or she is. And sometimes that's difficult because a person will come in and that person may not be complaining. It's easy when they come in and they say, I've been sexually assaulted, and we have a whole system by which we can help them. But when they come in and maybe, you know, we have a young woman that came in recently, she's just not talking. She's catatonic, you know, just staring and won't talk and won't move. And sometimes you have to almost try to guess what's going on, and we obtain collateral information and we try to look through the records and, you know, what might have happened to her, and then you have to try to appeal to deep down underneath whatever the effects of that trauma would be. How can we get through to this person? How can we help this person feel safe? And we know that early intervention, specific types of evidence-based therapy can be really effective in people who have been traumatized. But it's much more difficult when they come in and they're not just handing it to you on a silver platter, which is oftentimes the way it works. So I think helping people to feel safe, getting those therapeutic alliances established early is really important.
And going upstream from that a little bit, last fall, the state launched a campaign called Be Present. It's at bepresentohio.org. And it's a suicide prevention campaign that was designed by a contractor with direct feedback from Ohio's youth. And the campaign never mentioned suicide. It's about your presence is a present, and how to be a strong supporter of your friends, and how to look for signs if someone's struggling, and how to reach out to a trusted adult in order to connect someone with the kind of care that they need at that time. And so I think, you know, offering interventions at different points that help prevent that sort of circumstance from occurring are steps that we could all be taking in communities. And it's not a clinical approach, it's just teaching people how to be mindful and how to reach out.
So jumping, I know, there's lots of things I'd like to keep clapping about and say, let's keep going there. So this is building on each other. So Dwayne, with what was just said, so what is it? Can you give 2 or 3 examples of things that are actually working, whether in the school setting or in the family neighborhood setting, that actually are helping to address, people being present, being supportive, helping people move through the challenges?
There's some things that are very simple. Just what I was going to add to that, we had a young man recently who spoke at our luncheon about his experience with suicide, and he was struggling with depression, and he knew he was, and had his resiliency already in him, but decided to reach out to his network and told his parents, I need to get help. I'm not feeling good about myself. The comment from his father was, and it was a cultural factor as well, you're an embarrassment to the family. To go and ask to get help really is making all of us look bad. And so fortunately, he called the suicide hotline. So you can go old school in this, and it's still, we need this. I always think everything's on a continuum. You need all kinds of things. And fortunately, he did. They hooked him up with us. And he said a great thing at the end. He goes, it's really something that the point that I was the lowest in my life ended up being the best part of my life, of where he is today. So there's some kids that are just in certain environments, and they're going to be resilient through anything, but other things aren't. The other thing I want to mention about trauma is we always look at it, it's easy to look at it from an individual standpoint, but there is community trauma as well. And when you live in some impoverished areas or high gang areas, and this is a constant stressor that's put on the entire family. So sometimes we just have to bring it back. There's trauma-informed community building is a model that is being pushed a little bit more and explored more and expanded more. And I think it's a critical element because this is not ever going to be one-dimensional. So we have to keep pushing the boundaries out further and further.
And I think, just to jump on that, keep learning about what's working and supporting that and pushing it forward, in every way that we can. And actually, I just wanted to pick up, I've learned a lot in preparing for this, that there are some challenges. The Annie E. Casey Foundation they have a Race for Results Index. They ranked Ohio 42nd of the 44 states that they could collect data on for the well-being of African American children. And so I just heard Dwayne's story about this young man, because it turns out this young man is African American. And it's African American. So being an African American, these issues of race and culture and racism, toxic stress are very real. And I guess if you would go further, and maybe Tracy, anyone jump in, what can we do to address those issues more broadly? Because it's obviously going to impact a big number, and we should all stab our hearts to hear how challenging that is. We think about infant mortality. Here's our young African Americans, stressed.
It makes me think back about a year ago, Governor Kasich was meeting with some faith leaders from around the state, and there were representatives of the Somali population here in Columbus at the meeting, and they said at one point that we don't even have words in our language to describe some of the mental health conditions. And so just the engagement within the community is stymied in terms of, identifying that help is available, because it's not something that is traditionally discussed or addressed. And I think we need to look for ways that, number one, to identify that if a challenge exists in this regard, but number two, then, work directly with the community to identify what those needs are and how to address them effectively.
So that's not even the issues of shame and stigma. I mean, this is just culturally, there have not been experiences with that. I guess, and both Megan, you're a psychiatrist. These issues of shame and stigma are so real around mental health and behavioral health issues. It's not like seeing a diabetic. It's so different. What is it that we should both know, but we should take action to be able to help address these issues around mental health?
Yeah, so unfortunately, the stigma of mental health is still here, and I think one of the biggest things we need to do everywhere in the community is talk about it, open up the conversation. This could be in the workplace. If you notice somebody that's struggling, a coworker or one of your employees is showing up late for work, seems tired, seems sad, seems irritable, have a conversation. Oftentimes people are brought into the emergency department because a coworker notices there's a red flag, something's going on. And I think the way that I frame it to patients, a lot of times the patients don't totally get what's going on in terms of why are they mentally ill. They feel embarrassed. They say, I have somebody say this almost every day, I'm so depressed, I feel like I want to die, but I have a good family, I have a good job, I don't know why I feel like this. And I just bottom line it to them, your brain isn't working right. Okay, so if you had pneumonia, I would be able to show you a chest x-ray, and of course you would take your antibiotics. That's a no-brainer. If I could show you a functional MRI of your brain, and then of course they asked to see that, which I can't really make happen for many reasons, but I said if you could see a functional MRI of your brain, if it's a depressed person, it wouldn't be lighting up the way it should in certain regions. And this is totally simplifying it, or if you're manic, it's lighting up like the 4th of July when it shouldn't be. And when I frame it like that, sometimes patients just feel better because it's made to them so that they can understand this isn't my fault. And I usually tell them, I bet you have family members with depression. And if they say no, I probe them a little bit, and usually there's somebody that has an undiagnosed mental illness in that family. We also have to have that same discussion with families. I'll pull family members in and say, listen, he's not trying to be so mean. His brain isn't working right. He's manic, and his kind of mania manifests as irritability, and that's why he's so defensive and so on edge. And so I think really having this discussion, helping people, not just the patients, but also the family members and people in the community to understand the brain isn't working right. It's much like any other type of medical illness. We have to figure out what's wrong, and we got to find ways to fix it. Oftentimes it involves both therapy and medication, and it's not always a one-step, easy, quick fix. But we've got to be talking about it.
If I can add to that, there is one thing that you had just brought up is just when people think about themselves and how they feel about themselves and thinking about things. First off, somebody who's depressed or anxious, to ask for help is going to make them more anxious. If they're depressed, they don't have the energy to do that either. So everybody should be extending a hand of hope. But when you start to look at some of these things again in a much broader perspective, you have families who our work with Dr. Wade out of Children's Hospital in Philadelphia, we did an ACE focus group with him. What we found is that when we give the ACE, so adverse childhood experiences, it's 10 questions. It really measures what your trauma score is. We get it for the kid, and then we give it to the parent. And when parents looked at their score and saw, wow, I'm a 6, and now my kid is a 4, it's almost like showing them that scan. They give themselves a break. They step back a minute and think, so I'm a product of this as well. I can't continue to let this happen. So that's not, what did I do wrong? People are going to look at me funny or blame. It really shifted our focus. We've seen a huge increase in family involvement just because of that. So I think the more we talk about this, the more we put it out there, the more familiar people get with it, the better we're all going to be as a system.
So let me jump in on that. I just drove back a 10-hour drive and was chatting with my husband and daughter about this. And my daughter says, why is it, this whole shame and stigma, now there's this new campaign, I think it's called My Younger Self, I'll come back to that in a second. But she said, why don't we have mental health checkups as a part of our usual checkup? Isn't there such a thing? And why haven't we created a safe space for either individuals, she's 22, knows a lot of stuff that's going on. We haven't created safe spaces in our communities or at our universities for people to come forward, get help, talk about issues. We should have a mental health checkup. And I thought, well, I'm sure some people think they do that, but I don't think it's become routine. I mean, I'm wondering if some of us have been not so much driving it, but not lifting it up even in systematic ways to be able to talk about it. Do you have thoughts about a mental health checkup? Should it be a part of what all of us have?
Yeah.
Oh, go ahead.
Go ahead.
I was just going to say, we were really fortunate. We got $1 million appropriated to assist with suicide prevention activities in Ohio in the last few years. And one of the things we did was outreach with primary care, because many people who attempt suicide or complete suicide actually see their primary care physician within the month leading up to their death, and so, or their attempt. And so that's a point of intervention. And just to ask some basic questions about how are you feeling, you're depressed. I mean, we have codes that actually reimburse to screen for substance use disorder and do a brief intervention, but we don't, at least with Medicaid, do the same thing with mental health.
Yeah, and I think this brings up a great point because really there's such a shortage of psychiatrists. This has to be happening in primary care clinics. And so a huge project that we've recently launched at Ohio Health is to actually go into primary care clinics It's called behavioral health integration, and meet them where they are in that primary care setting. So there really is more of a psych or a mental health checkup. We're providing consultation services, both in person and via telemedicine, to sort of combat that access problem, that lack of psychiatrist problem, and then also providing the case management and the social work piece right there in the primary care setting. So I think that's really going to be the future of how we're going to address this problem and ensure that there is sort of a psych checkup every time you go to see your regular doctor.
It's terrific. So you too, as you know, in the CMC way of going about these conversations, in just a moment we'll have an opportunity to pose your questions to the group. So again, I don't see it, but it's over there. It is. The microphone is over there. So please, in just a moment, don't be shy. Step up, because it's your time to have the conversation and ask the kinds of questions that you'd really like to pose. So let me come back with one. The issues of suicide, the issues of what's out there, fake news, social media, et cetera. I guess my question is, are there activities that we should be thinking about? Is there a way to use information technology in a way to support our mental health? Monitoring it, Tracy already mentioned monitoring, but are there things in this day and age that we should be doing? And do you at the same time believe that it's actually driving some of the spikes that we're seeing in mental health issues?
I don't know if this directly answers your question, but the state recently launched a website called boldbeginning.ohio.gov, and it's information from pregnancy to third grade on mental well-being, physical well-being, developmental milestones and delays, all things related to early childhood. And there are component parts in there about bullying and about toxic stress, even at a young age. And I think that a key component of this is just education and making it okay to talk about concerns that parents have for young people at a young age, because that's really the best point of intervention when you identify it.
And that parental component is really critically important. It was, when I was growing up, it was easy for my parents to say what I'm going to watch on TV and what I'm not. When you have kids today that really have access 24 hours a day to any type of media, that's very, very difficult to monitor. I get concerned that they end up starting to look for that for information too. So you have to have these discussions. The discussion you had in the car, that's part of that has to be a part of this piece. Parents have to be able to talk to their kids and be willing to, and just ask the questions about how are you feeling? Have you struggled with depression? It's amazing to me at times when we get families in treatment and we ask about, have these things surfaced before? Have you had these discussions? And it's not. And that's something that's so simple. And you don't have to pay for it. It's there. And it should be a part of just a daily interaction.
But this is hard for families, and families have such different contexts and issues going on, so sometimes it needs to be another caring adult or someone else who can start to open up some of these conversations. It's a challenging time, for sure. So, one other thing, just to tease, I'll have another teaser in a moment, but there are things going on. I just learned about it. I didn't get to go and learn more about it, but as far as using artificial intelligence, virtual reality to help think about some of the work the military has been doing, some of the medical informatics are really driving. How can we use some information technologies to address mental health issues and suicide prevention in particular? So stay tuned into the future. We should be all learning more about that. So great, and thank you. So our first question, and I guess I would also be sure to step up and don't be shy, but also in fairness to everyone, we'd like to get through as many questions as we can. We're already getting a good group. So please, let's get started with the first question and go from there.
I don't know if it's on. There it is. My name is Katie McDonald. I am a guest here today. I have a full page of notes, and I have so many questions, but obviously going to be respectful. I recently lost my boyfriend to suicide. And what I hear a lot of the talk about is about white privilege and people who have access to care. But what I'm curious about is that he was battling mental illness very outwardly for about 5 years. And the way that we were able to help was not enough, clearly. How can we get better at as family members, friends, at being advocates for those who are struggling, for those who may not quite understand what it is that's going on with them, who may be, he didn't like taking pills. He was being treated for schizophrenia, but was also experiencing mania. We were working on a schizoaffective disorder diagnosis. He was not being treated for the mania. How do we get better at advocating for them when we can see that it's not working, that it's not enough? What can we do for people who are not children and are not minors?
So first of all, thank you for coming forward. I am so sorry for your loss, and I have to tell you, this is my number one, closest to my heart topic. If you give me a choice of what to talk about every single day at a lecture, at a discussion, this is my number one. I have trouble not tearing up when I talk about this myself, and I do it every single day. So I think this is tough no matter what, because something we struggle with as psychiatrists, and we have open discussions about this. Even recently at our national conference, somebody went forward, a psychiatrist who had a patient who suicided, and we all talked to him, and one thing to do that I'm guessing you were doing is just to be in very close touch with the provider, right? The therapist, the case manager, if there is one, the psychiatrist, because I think it's not always clear to providers that there's so much else going on that they're not hearing about, right? So we hear one side of it from the patient. This happens all the time in the emergency department. And we know that that's only one small part of the story. Now, that becomes complicated when the patient has to provide consent for you to talk to the provider. So I think being in close touch and sort of providing your standpoint at all stages of the treatment as to how you, the family, or the support system feel objectively the patient's doing, if there are things going on the provider's not aware of. I think from the community standpoint, now that that's happened to you, it's such a terrible tragedy, but you definitely can use your story to try to help other people. And I think through the American Foundation of Suicide Prevention and wonderful groups like that, you can get involved. And I think sometimes hearing someone's story, I'm always trying to give media interviews on this. Like I would talk about this every single day, but they always want a family member of somebody who committed suicide, and that's so hard to get people to talk about. So I think sometimes if you can use that story to help other people identify warning signs, that's a big one with you. It probably wasn't as much of that. You already knew that there was this illness going on, but helping educate society as to warning signs, because it may be somebody's classmate or teacher or friend or family member. But certainly this is just something that none of us are okay with, and we want to do everything we can to try to prevent this, for sure.
Is there anything else that was a great answer. Okay, great. Thank you. So, Eric?
Thank you, Teresa. Eric Davies. So a lot of times when we use the term mental health, behavioral health, it seems like a very individual term, and that we're labeling people and they have a mental health, behavioral health issue, and we need access to deal with it. But, and I appreciate knowing Teresa too, coming out of her mouth, the words, the social determinants of mental health. And when I think of those social determinants, and I appreciate the discussion about that today, a lot of times it seems like if we label that mental health or behavioral health, society kind of still sees that as an individual problem, when those social determinants are really societal problems around racism, poverty, gender identity, grades, getting into colleges, family stress, peer stress, technology stress. So do we need to be assessing some of these issues differently? And if we do, then do we label them differently and thus hence intervene differently?
Yeah, I think anytime you do an assessment, it's going to be, like a biopsychosocial deal, and you're really going to look at all the support networks and everything else that's around them too, and it's important to look at that. A clear example, there's always outliers even with different groups, and when you look at racism and separation, let's just look at the LGBTQ, T, G, and C populations. For kids, now all of a sudden suicide goes up 4 times. Well, this is an outlier. Homelessness, they make up 25% of the homeless kids in the country. These are other factors that are playing into this whole picture, so you must look at the entire picture, because the answer isn't going to be an individual answer. it's going to have to be a more broad-based answer. It's going to have to be a community answer.
I would just add, because again, learning, and these panelists know it well, the social determinants of mental health are really a kind of a subset of these broader social determinants of health. But in particular, WHO pulls out social inclusion, freedom from discrimination and violence, and access to economic resources. So even with all of those going for any one of us, we could still have big issues, but these clearly are where people get marginalized, bigger issues would be expected. So it totally makes sense. We need to think about that when we're assessing in our mental health checkups, et cetera. And how do we support each other, support a family member, support a partner in trying to address those and trying to reduce those as much as we can. Yes.
I'm Marian Harris. I'm also a volunteer for the Suicide Prevention Hotline, so I've had some close calls. Anyway, my question is around education. Are students in medical school, teachers, whatever, as they're being trained, are they getting the kind of education that would enable them to do so much of what you're talking about, being able to recognize problems before they become problems?
I don't know that it's built into all of the education curriculums in colleges and universities around the state, but what I do know is that we're working today with the Ohio Department of Education to refresh training materials for not only teachers, but also other school professionals and students about how to recognize the signs and symptoms that someone might be struggling, a young person, and then how to connect them with local resources. It's been interesting, just in my travels around the state to meet with I could think of a particular guidance counselor who said, well, I don't know where to send people. Well, her school district actually has a contract with a mental health services provider but people just don't know. So we're putting together some information, and that'll be available at the beginning of next school year.
And Tracy, can you speak a little bit more, because I know you're involved, as far as there's also education that's going on around the state and moving forward and maybe revised, as well as substance abuse and some of the signs to try and look for early on or to build resiliency so our young people are given support, and their families, as far as avoidance or changing what could be at-risk behavior.
Yeah, and I see that your June discussion on children's mental health, you're having Dr. Dennis Embry speak. We have actually invested pretty significantly in his product that focuses on classroom management techniques and building self-regulation skills within young elementary school children. Because if you can help and make it fun to work as a team toward self-regulating behaviors, that will help you later in life as you mature. And that has been shown to decrease the odds that you will begin to use substances that you shouldn't be using and form addictions. And so that's one example of how we're trying to go upstream again.
Right, and it clearly helps address those adverse childhood experiences, et cetera. Obviously, saying all that in light of the challenges that our teachers are facing, and that's really true across this country, I'm sure across our state. I was just struck last night on the news, they were saying that teachers on average across the country spend $500 of their own money on supplies. So we need to, as a community, and obviously as a state and a nation, figure out how do we support our teachers, both financially, but obviously with information so they can help their students, the families, et cetera, be in as good a place and moving forward as they can. So thank you. Yes.
Hi, I'm Jaren Terry. I'm president of PFLAG Columbus, and I'm glad to hear that you mentioned LGBTQ children, because the Human Rights Campaign just came out with their LGBTQ youth report that talks about the higher incidence of low self-esteem, depression, and anxiety among these children compared to their peers. And I'm very interested in hearing what you have available that's targeted for these kids, or maybe someone on the June 6th date can address that specifically. Thank you.
I mentioned earlier our Be Present campaign, which was launched in the fall, and there were some focus groups specifically with youth who identified as LGBTQ, and that was a specific audience that we wanted to make sure that we were speaking directly to with the campaign. So that's one thing our department's been involved in recently.
I would just add, because it was of particular note to me as well, because there are groups in our LGBTQ youth and actually all across the board have increased challenges, and the rates are amazing, is this new campaign, and maybe some of you know it better, but my Younger Self campaign. It was actually getting some attention when I was up in Canada. But it's celebrities, and I don't know if you've heard about this, but it's various celebrities looking back on their life and about their mental health issues. Obviously, we just learned, with Margot Kidder's death about, obviously, her challenges. But these are still living celebrities talking about their youthful experiences and coming forward and saying, please step up, ask questions, express your concern, and know, just as Dwayne had said earlier, it takes courage, so be courageous in stepping forward and that you can do it. And I know that several of them are speaking from the LGBTQ experience. So maybe, I don't know, is there data to show that these kinds of campaigns make a difference? I hope. Oh, there are definitely services locally.
There are. We actually looked into this like 3 years ago just because whenever we have outliers in our caseload, and interestingly, it was really the transgender nonconformist population that actually brought it more to our attention because they're appearing more and more in our general mental health caseload. So whenever we see those outliers, we really start to look at all the factors around that, and do these variables really call for them to have a more individualized program? And we decided yes. So we do have a program for that. There are many agencies that have programs specifically to address this population. What is that? In our agency, it is called Project Pride.
Great. Our last questioner, and
yeah, my name's Brandon Morgan, and I'm just curious what your opinions are about what kind of practices are most effective for preventing kind of the onset or manifestation of symptoms of mental illness.
Oh, let's take that away. No, just kidding.
Okay, so that's a big one. I don't think I'm going to be able to cover all of that in like 1 minute as they're giving the time sign.
Tomorrow.
Yeah, so I mean, I think the bottom line is with mental illness in general, there's a genetic and an environmental component, right? So there's not much you can do about the genetic component. We know that for many people, for instance, with depression, an episode, a first episode or a recurrent episode will be manifested during a stressful time. So I'll just use as an example, I think there are many types of mental illness that it's going to happen at some point. It's just a matter of time because somebody's genetically wired that way. But particularly when we look at something like PTSD, post-traumatic stress disorder, when someone's exposed to the trauma, we know that there are certain factors that will increase the likelihood that it'll develop into full-blown PTSD. And so as I mentioned earlier, early therapy and early intervention can help to prevent the full-blown onset in some cases. But with depression, I think identifying those symptoms as they're coming on and trying to, again, if there's a stressful time where somebody who has known depression or has a family history of depression may be at a higher risk for having an episode, identifying those sort of red flag warning signs, getting them plugged into treatment sooner. But a lot of times it's not something that can simply just be prevented because there is that genetic component. I do think that the environmental pieces can be modified to some extent to try to minimize the severity, if that makes sense. Does that answer your question? Kind of?
So with that, I just want to give a teaser, and it may play right into the last question and to multiple of them. Obviously, this is a huge and important topic, and so the commitment has been made by CMC to continue this dialogue with an additional panel on June the 6th, where we're going to take that deeper dive and look exclusively into the mental health issues of our community's youth and adolescents. It's part of our Healthy Community series, and there will be national experts joining some of our local experts to both share their perspectives but also answer your questions. So with that, hopefully you'll all come on June the 6th. We'll continue and go there. And Carol, back to you. And again, let me thank both Tracy and Dwayne and, of course, Dr. Shabbing Megan. Thank you so much for being our part.
Thank you, Teresa. I hope you all found today's forum informative. We encourage you to continue the conversation with coffee and cookies out in the lobby. Please help me thank our sponsors, Ohio Health, Mount Carmel Health Systems, Osteopathic Heritage Foundations, and Nationwide Children's Hospital. And I also want to thank our speakers, Dwayne Caceres, Megan Shaving, Tracy Pauk, and Teresa Long. Thank you very much. And thank all of you for being here. I hope we see you at our forum on Friday and again next Wednesday. Thank you.